these patients that are getting into the ICU with COVID-19, a lot of them have underlying respiratory comorbidities, COPD, asthma. How much of that is a risk for being, for having a complicated course with COVID-19? And how do you manage that, just from the prevention standpoint to when you have to ventilate these patients?
It's a great question, Greg. And one aside I'm going to mention now, I've talked to a couple of colleagues now, and none of us with busy pulmonary hypertension centers have seen a case of COVID in a patient with pulmonary hypertension yet. I don't know why that is. It might just be coincidence, and we'll see. But I wonder, I mean, there's got to be some genetics here. And I wonder—
Or could it be that they're on anticoagulation, Vic?
It could be. We haven't even seen the COVID infection yet. So
Yeah.
I'm even wondering if somehow the BMPR2 gene mutation or something plays a role here. You see, interesting point, Greg. I'm certainly not going to stick my neck out too far, but I would love to look at that a little further. But I think to get at your point, someone comes in with ILD, COPD, emphysema. Sure, I think they're more susceptible. And this disproportionate hypoxemia that Alex mentioned, it's a big point. I mean, it's like a big PE sort of. It's dead space ventilation. You're seeing little infiltrate, severe hypoxemia, and you've got underlying emphysema or ILD. You're already on 6 liters of oxygen at home. I think your risk is higher. And do you benefit patients by proning them in those situations or not? Is it better to delay intubation or not to delay intubation? 15 years ago, we didn't use high flow oxygen. Now we use high flow oxygen. People are on, 40 liters per minute of oxygen, a ton of oxygen. And maybe, many people feel like you can stave off an intubation longer if you're careful and monitor oxygenation carefully. But again, you don't want to wait too long and have a crash intubation. And we're lucky that I'm not in there in the room intubating patients now. We've got very good anesthesiologists that do that and do it very quickly. But I think your question is, yeah, I think these patients with underlying lung disease clearly have a higher risk of doing poorly. But I will say, again, I want to keep sticking a little bit of optimist point in there. And that's it. Gosh, I'll tell you, some of these ICUs, as we get more experience, have done a really great job. We've gotten elderly patients with bad lung disease off ventilators, not all of them, but while it's a problem and clearly I think does increase the complication rate, we're getting better at dealing with it, I think.
Greg, can I make a statement? And Vic,
absolutely, Alex.
Yeah, you're a penultimate optimist, and maybe I'll say something pessimistic. But what's interesting to me, Vic, is that when you look at the literature, albeit fairly low quality data, but also our own experience at Northwell, these patients, whether they're in the ICU or not, seem to have breakthrough clots, despite what was a previously adequate anticoagulant regimen. So despite being on chemoprophylaxis, we're seeing a lot of patients have breakthrough clots and be quote unquote resistant to these types of regimens. So again, we have done one, again, non-published experience at Northwell and have found a prevalence using screening lower extremity 2-point ultrasounds in the ICU of DVT as high as 40%. And indeed, some of the most recent data out of Europe is suggesting a prevalence that high, 30 to 40% using screening methods. So to me, it's fascinating. There's something about this disease that's, again, very thrombogenic and is very resistant to the usual modalities that we've done for the last 2 decades or so. Quite fascinating.
I think there's a real dilemma, Alex, because right now, I think I still have equipoise. For example, randomizing a patient to enoxaparin 40 milligrams once a day versus a more aggressive regimen that comes in with COVID and no proven VTE yet. And maybe with criteria including high inflammatory markers, D-dimer, et cetera, but it worries me more and more as the week goes on. I think we're going to get data here. Maybe it'll be your study, Alex. We're going to get some data here pretty soon. And I hope we can make better decisions, because I'm starting to worry more and more that prophylaxis alone may not be enough.
Yeah, I couldn't agree with you more.